Okay, so my task is to discuss AF pathogenesis, current understanding, and potential ablation targets in 2023 or 24. Not an easy task. Even in 2024, AF is very complex. We don't yet understand all the aspects of AF pathogenesis. However, the current understanding is that there are probably three components of AF that are important in pathophysiology of atrial fibrillation. There's the triggers that initiate atrial fibrillation. This could be pulmonary veins or extrapulmonary veins. There are the substrate that maintain atrial fibrillation, and then there are modulators that interact with both the triggers and the substrate. What I will try to do in the coming 15 minutes or so is to discuss each one of these components with specific focus on targets for ablation. So since the initial description by the Hasegaert group, pulmonary veins isolation is the cornerstone of AF ablation. However, even back then, there was this recognition that there are extrapulmonary vein triggers that can initiate atrial fibrillation. This was replicated by other groups. This is, for example, UPenn group, where they systematically looked at triggers of atrial fibrillation, and in their experience, up to 9% of patients have triggers outside of the pulmonary vein. And over the years, people have tried to develop predictors of extrapulmonary veins. The list is long. Perhaps important ones are female sex, non-paroxysmal atrial fibrillation, and old age. And just recently, there was this scoring system that can help you predict who's going to have extrapulmonary veins based on 4 independent predictors. And you can see how the more factors you have, the more likely you're going to have extrapulmonary vein trigger. There's also some AI work based on imaging, CT imaging, that can predict before the procedure who's going to have extrapulmonary vein triggers with reasonable accuracy. Now, the goal of all of the previous work is to target these ablation. Another way of doing it is just to empirically ablate, and this is what we do with pulmonary veins. I think most labs just do empiric pulmonary veins without actually showing that pulmonary veins are the triggers for that specific patient. And if you review the literature, you'll find that obviously pulmonary veins have been shown to be effective, even if it's done empirically. There are things that have been shown to be not effective, like linear ablations. And there are things that need more work, such as vein of Marshall ablation, posterior wall isolation. And there's the issue of left atrial appendage isolation, which has been shown to be effective. However, it's still unclear if the benefit is from the isolating the appendage itself or reinforcing the isolation of pulmonary vein. The other way, which always has interested me, is why don't we actually study the triggers for each patient, just like we do with other arrhythmias. I don't think it would be appropriate for SVT, for example, to just go and do empiric slow pathway ablation, because this is the most common. But somehow this got lost in translation where we do it for AF. And I think it's fair to say that the comparison is not the same, but the concept is. I'm only aware of one study that's going to examine that question in a randomized clinical trial fashion, where patients are going to come to the lab. You actually do the triggering protocol and ablate if there's an extrapulmonary vein, and we'll see if that improves actually outcomes. So moving on to the substrate, and substrate could be because of structural heart disease, but also could be because of AF itself. The recognition that substrate is an important part of the pathophysiology of atrial fibrillation is actually old. This is the first paper that described that, and it was probably at the same time as the Hasegaert's group publication, where they showed in an animal model, if you pace the atrium and induce AF, and then you do histology, you get interstitial fibrosis, which maintain atrial fibrillation. And then with the development of 3D mapping, we were able to correlate low voltage on 3D mapping with SCAR, and this has been shown to be a strong, independent predictor of recurrence post-PVI. The next logic step was to ablate that SCAR, and there are multiple studies, both randomized and non-randomized, that showed reduction in AF recurrence post-PVI if you target these low voltage areas. This is mostly seen in non-paroxysmal atrial fibrillation, and I'll talk about that later, but it appears that in paroxysmal atrial fibrillation, triggers are the most important aspect of the pathophysiology, whereas when you progress to non-paroxysmal, you get more of the substrate and modulators. And then people try to do this non-invasively. So before even getting the patient to the lab, can we assess SCAR using MRI? And this is the DCAF study where they looked at SCAR on MRI and showed that the more SCAR you have, the more likely you're going to have AF recurrence post-PVI. Again, the logic next step was done, which is let's ablate that. Unfortunately, this didn't show any benefit. So if you go and target that SCAR, it doesn't seem that you get less AF post-ablation. Now, why that is still unclear. One probably important reason is that there is poor correlation between scarring on MRI and low voltage on 3D mapping. So maybe we're ablating areas that are not scarred if you only base it on MRI. The last thing is the modulators, and these are very important. I am not going to talk about risk factors. Dr. Mohsen is going to give us a talk about that because this is not an ablation target, but it's an important target. In terms of ablation targets, autonomic nervous system has been a focus of interest as an ablation target, and this interaction between autonomic nervous system and atrial fibrillation is also complex. It appears that the autonomic nervous system modulates some of the effect of risk factors, but also has direct effect in atrial fibrillation, and atrial fibrillation by itself has a direct effect on autonomic nervous system. When it comes to the basis of this observation, it's the increase in heart rate post-ablation. This is one of the early observations post-PVI where you see increase in the sinus rate as a marker of autonomic nervous system modulation. There are multiple studies that showed that there's a correlation between that and the reduction in AF recurrence. This is a nice study because it showed what appears to be a dose-dependent effect. The more increase in the heart rate, the less atrial fibrillation you get post-PVI. And then if you divide the group into 11 beats per minute increase in heart rate at 3 months, you get a significant reduction in atrial fibrillation. This is adjusted for medications and antiarrhythmics. So the Eradicate AF clinical trials try to actually not only depend on ablating ganglia as we do PVI, but actually targeting the autonomic nervous system by doing renal denervation. The way they did it is they actually used the ablation catheter itself. They reconstructed the renal artery and then ablated from the distal bifurcation to the proximal artery, 5 millimeter lesions, spiral, and then showed significant reduction in AF recurrence if you add that to PVI in paroxysmal atrial fibrillation. This actually has been shown in multiple studies, but very small studies, but the effect appear to be similar. So with that, if I want to summarize what we understand about targets in 2024, it appears that triggers is an important part in paroxysmal, and perhaps PVI is good enough, although it's not ideal, but good enough to be the starting point. As you progress to more persistent and long-standing persistent, PVI is not enough. There are 4 potential targets for ablation. These are low voltage area ablation, vein of Marshall ablation, renal denervation, and maybe posterior wall or left atrial appendage isolation, but more evidence will be needed to know when, how, and how many do we need to do. And with that, I'm going to conclude. Thank you.